try to run through a quick overview of male factor infertility in the next few minutes. There are many definitions of infertility, and they keep on changing every decade or so. But the most agreed upon definition is failure to conceive after 1 year of proper trial. Up to about 15% of couples are infertile. You can see from this graph that about 50% of infertility is due to a female factor, 30% is to a male factor, and about 20% is due to a combined female-male factor. So about 50% of infertility does have a male factor component. And in certain societies, certainly such as ours, this gets neglected sometimes or put on the back burner. The woman is blamed, she goes through multiple investigations, finally until the man decides to arrive to the clinic and gets a proper evaluation. Although the male evaluation is much simpler, much faster, much more accurate than the female evaluation. We don't have exact statistics in this part of the world, but we know it's very common in a place like the US. And even in a liberal society such as the US, only 20% of partners receive a medical evaluation for infertility. Another common theme is that most urologists are not interested or not trained in male infertility patients. And that today is not true, at least in Saudi Arabia. Over the past 20 years, there has been a plethora of urologists who are trained in andrology and infertility and doing very well. So, basic evaluation, we follow the simple approach of history, physical examination. Then we do some lab tests, including a semen analysis and a hormone profile, and potentially other tests such as an ultrasound of the scrotum. And then we decide whether there's reversible or irreversible fertility. If it's reversible, is it medical or surgical? And if it is not treatable, then we look at alternative techniques such as artificial insemination, IVF, XC, etc. So let's talk initially about the evaluation. We know that sperms are made in the testis, right? But we know that there's a journey for these things to go through. Within the testicular tubules and seminiferous tubules, the sperm cells are formed. They take about 70 days to form. They need another 14 days to mature within the epididymis and travel until they're deposited in the vesicle.
Sure.
So essentially, it takes about 80 to 90 days for the sperm to be formed, to mature, and to make its way up into the seminal vesicle, where eventually it is excreted with semen. So it doesn't make sense that you would make a treatment today and expect a response in 2 weeks, right? You need at least 90 days. In fact, you need maybe 2 or 3 cycles for the old sperm within the seminal vesicles to be emitted and then replaced by new sperm. So you need multiple cycles before you see a difference. Now, history. Let's ask the gentleman in the room here. What do you think Arnold's cause of infertility would be? So, have an answer? All of the above, yes, I think so. Every one of these factors, that's why taking a history is extremely important. We sometimes go for the obvious, but sometimes the non-obvious is also very important, yes. So, for the fertility to happen, there has to be coitus, and coitus has to be at the time of ovulation. So if you're not having regular coitus, and if he sees his wife twice a year, okay, has not had enough time, okay, to fulfill the definition of fertility of unprotected intercourse over 1 year. We have this problem very commonly in Saudi Arabia, where we have lots of non-Saudis and even some Saudis who work in one city and their wife works in another city. They might meet each other once every 2 weeks or 3 weeks. That is not enough to, they may get pregnant, certainly, but they have not had enough chance to have coitus at the time of ovulation. Once they've ovulated, they only have those 12 to 36 hours to be able to, for the mature sperm to meet the ovum and to actually fertilize it and get pregnant. So that's why history is extremely important. Sexual history is important. Timing of coitus is important. Many other questions are very important. So don't forget taking proper history in someone with presumed infertility. The duration of infertility is very important, as I mentioned. Someone comes to you, they got married 2 months ago, my wife is not pregnant. You gotta wait, okay? It doesn't happen overnight. Whether the patient has primary infertility or secondary, whether this is with the same wife or a different partner, how long has it been since the last child was conceived, the use of contraception, the use of previous evaluations, previous treatments, very important, and family history is also important. Sexual history, we talked about potency. Many people have not had proper sexual education. They don't understand how to have proper coitus. Both the man and the woman, many times they have unconsummated marriages coming to see a gynecologist. So there are other reasons for infertility apart from just simply having a true male factor of sperm production. Use of lubricants during intercourse may kill, they're spermicidal, they may kill the sperms. The frequency of intercourse, the timing, as I mentioned, to be around the timing of ovulation within the ovulatory cycle of the patient. History of undescended testis and whether it was surgically repaired or not, and when was it surgically repaired? Was it at before 1 year, at 5 years, later on in life? Also affects that testis ability to produce sperm. Bladder urethral reconstruction may again cause problems in the urinary tract and the genital tract in depositing these sperms properly. History of testicular torsion, trauma, previous infections such as mumps or orchitis. Onset of puberty, another very important question to ask. If there's delayed puberty, may give you some clues of hormonal imbalances. And a history of cystic fibrosis. Cystic fibrosis, although it's a lung condition, but may be associated with absence of the vas, congenital absence of the vas deferens. General medical history is very important, whether the patient has had systemic illnesses, even a febrile illness, even a bad flu. If you check a semen analysis of a patient 3 to 6 months after a bad febrile illness, you may find a dip in their sperm count. That's important to know. Chemotherapy, a big one, very big one, may cause أحيانا reversible, أحيانا permanent infertility. Radiation therapy to the pelvic area or to the testicular locations. And as I mentioned, previous history of mumps on the testis or STDs, again, a very common factor in causing obstructive types of infertility. Surgical history, also an important one. Previous history of scrotal surgery, hernia repairs. Previous prostate surgery may cause anejaculation or retrograde ejaculation. Same with retroperitoneal surgery may cause anejaculation. Previous pelvic injury, blasts, fractures of the pelvis, trauma may cause strictures. And hernia repair may cause obstruction of the vas deferens. They cannot be noticed. These are still in the history right now, okay? So once you have the history, you may start building a story. So, for example, patient had hernia repair on one side, but has another very healthy testis on the other side. There's no reason for me to think of obstruction unless there are other causes. But if he had bilateral hernia repair and he had a child before the hernia and now can't have a hernia, well, okay, now a light bulb goes off and says, okay, maybe something happened in the previous surgery. So that's how you build things. Gonadotoxins, again, we talked about chemotherapy, radiotherapy, alcohol abuse, tobacco abuse, marijuana abuse, anabolic steroids, a very big thing, unfortunately rampant in our society, rampant in your age category, badly abused in gyms by personal trainers. You got to spread the word for your colleagues, your friends. Be wary of these. These are quick fixes for fitness and muscle mass, but they can temporarily or permanently damage a young man's fertility. Physical examination, again, looking back at Arnold. So there are certain, how do you say, what we call eyeball exams. The minute the patient walks in the room, I can sometimes identify certain syndromes. For example, Klinefelter syndrome, where the patient has a typical appearance of being a tall person with a very wide span, with very little facial hair, maybe even gynecomastia. Quadriplegic patients in wheelchairs, you'll have an idea that these patients may be having emission issues or even erection issues. We talked about gynecomastia, previous abdominal scars, pelvic scars, etc. may give you also an idea of what may be going on in terms of obstructive causes, etc. Penile anatomy is important to address. The location of the meatus, whether the patient has epispadias, hypospadias. This may affect during vaginal intercourse whether the semen is deposited within the vaginal vault or outside. Testicular size, consistency, location, the presence of the vas difference. Every now and then, about 1 to 2% of patients, we may find an absent vas difference, and that may be a contributing factor. Epididymal congestion. Of course, the most common finding, the most common reversible cause of infertility, what we look for all the time because we can reverse it, we can fix it, is varicocele. And it's a very common finding amongst normal men. So about 10 to 50% of normal men off the streets, if you examine them or do an imaging, you will find a varicocele. And a rectal exam is sometimes important when you're expecting prostate disease. We talked about the position of the meatus, and this is usually very obvious on exam. Epispadias, hypospadias, especially, distal hypospadias is not a cause of infertility, but proximal hypospadias is a contributing factor to infertility. Testicular sizing, you can do sizing with orchidometers, you can do sizing with a ruler, or you can do just an ultrasound and that'll give you the proper size as well. The normal size of the testis is about 4 centimeters by 2 centimeters in size. Varicocele, sometimes very obvious on physical exam, and you can see the bag of worms under the scrotum. And the incidence, as I said, is up to 15% within the normal population, and about 37% of people with infertility will have varicocele. So it's a very common cause and a reversible cause of infertility. We talked about cystic fibrosis and how some of these patients have a congenital absence of the vas difference. Honestly, not a very common condition, especially not in our part of the world, but every now and then you will see a patient. Okay, so we've done the history, we've done the physical exam, various clues. We've gathered tons of information here, and now it's really important to put this information to the test. Does this patient have infertility or not? So the most obvious test to do is a semen analysis. Pretty simple, pretty straightforward. Instruct the patients at least 3 days with no coitus and submit the specimen within half an hour to the laboratory at room temperature. And we like to depend on at least 2 consecutive semen analyses, maybe 2 to 4 weeks apart. We may do a hormonal profile. We look at 4 hormones essentially: testosterone levels, prolactin levels, the LH, luteinizing hormone, and FSH, follicular stimulating hormone. Now, what is normal in a semen analysis and what is adequate for pregnancy? This has been, again, an area of controversy and an area of update after update after update by the WHO of what constitutes a normal semen analysis. And it keeps on changing every decade or so as well. As I mentioned, it's not just important that we have an adequate number of sperm to achieve fertility. That sperm has to have enough motility to be able to go through the vaginal mucosa, cervix, endometrium, and hopefully meet the ovum within one of the fallopian tubules. So it has to be not only moving, it has to be progressively moving, okay? So the first thing we look at is number. The second thing we look at is motility, in particular progressive motility, because there are 4 types of motility. There is forward progressive motility. There is motility with no progression. There is motility within its, around itself, and there is dead sperm not moving. So the type of motility is also important. And the third factor is morphology. We have to have at least 4% of our sperm having a normal appearance, so they would be able to penetrate the wall of the oocyte and cause fertilization. Okay. So this was the old definition. This definition, as I mentioned, has changed a couple of times since. But generally speaking, we look at certain parameters. You look at the semen volume. And if the semen volume is low, you think, maybe there's an obstructive cause within the prostate or the seminal vesicle. We look at sperm count. It used to be 20 million per ml. Now it's down to 15 million per ml. We look at motility. It used to be a flat more than 50%. Now we say no. You can have either 50% of total forward motility, or you can have 25% of grade A motility to be adequately considered normal. Morphology. We used to use the 30% rule. Now we use the 4% rule. So things change. It's always good to look at the reference number at the lab that you are using. So every lab will have references, and you can, whatever you're practicing, you would look at that lab's normal values. The sperm also has to have good viscosity, no significant agglutination. Pyospermia, again, a sign of infection or sepsis. So if you find white blood cells in high numbers in the sperm, we consider that infective, and we treat it with antibiotics. So that being said, and you see some of the vagueness I talked about in terms of what's adequate in sperm count, what's normal. And there are various labs and various references. But there's no variability if there's azoospermia. That's pretty straightforward, right? There's no sperm, the patient has no fertility. That's pretty clear, pretty straightforward. The other thing we want to talk about is the hormones that control the process. And these come from the anterior pituitary. You've probably done this with the negative feedback loop of LH and FSH. So in other words, if the patient's LH or FSH are low, you can think maybe this patient has a central problem, a pretesticular problem, and you would give them hormones. As opposed to someone who has high LH, high FSH, it means the testis is not producing, patient's azoospermic, okay? It's giving signals from the pituitary gland to the testis, and these signals are continuously being produced, which are the hormones, but there's no production. So that's how you can identify which is which. Is it testicular or pretesticular cause of infertility using the hormone tests? Every one of these hormones, you can read about them, has a function. FSH initiates spermatogenesis. LH is androgen production. Testosterone is also important in initiating and maintaining spermatogenesis. And prolactin may cause arrest of spermatogenesis if it is high. So we've done the evaluation. Now, how do we treat? Not every cause of infertility is reversible. We try to identify, first of all, what is reversible, and we try to address it if we can. Like I mentioned, varicocele is the common cause of infertility that is reversible by doing surgery. There are various surgical techniques. The most, the newest one and the one with the least complications is microsurgical varicocelectomy. Idiopathic causes are very common, the second most common cause of infertility, and usually we treat these with either empirical therapy, has a low success rate of 20%, or we go for assisted reproductive techniques such as IVF or ICSI. Obstruction is caused about 15%. All the rest have various degrees of incidence, and they're honestly not reversible. Varicocele, for the interest of time, we won't go into the mechanism of how varicocele causes infertility. There are many hypotheses out there. It's usually diagnosed on physical exam. It's confirmed on ultrasound, where we have reversal of flow. So two mandates for or definitions of varicocele is you have to have dilated veins and you have to have reversal of flow on Valsalva maneuver. If you have that combined with a oligospermic or a astenospermic patient, you would go on to perform varicocelectomy. Like I said, it's usually done through a small subinguinal incision. We deliver the spermatic cord into the incision. We separate the varicocele veins from the rest of the cord. We clamp them, tie them, and we repair them. Now we know that we have improved sperm count and sperm numbers in about 70% of patients who undergo varicocelectomy, but not all of them will get pregnant. Only 40% of those will actually go home with a baby eventually. Obstruction, like I said, there's a testis is produced in the sperm, epididymis goes to the vas deferens, and then is deposited in the seminal vesicle and then emitted. So you can have obstruction in any part of the genital tract. The most common cause of obstruction that we can reverse is either that after a vasectomy. So many people, especially in Western countries, will undergo a vasectomy, and 5 years later, 10 years later, will decide, oh, maybe I did a mistake, I want to reverse it. That's pretty obvious. So we can reverse a vasectomy with microsurgical techniques. But another common cause in this part of the world are usually infections. And these infections usually cause an obstruction between the epididymis and the vas deferens. And that's where we do the surgery. First, we have to diagnose the patient. This is based on low volume of ejaculate, low motility, a distended epididymis, normal testicular sperm production. Hernia is another cause of obstruction where we can go and after it and fix it. We talked about vasectomies, and we are beginning to see this more and more in this part of the world. We're seeing many people who have, lived, worked, or studied in Western countries, who sometimes have made hasty decisions by having a vasectomy, have come back and asked for a reversal. Reversal, you talk about the success based on patency and based on pregnancy. So patency is high. We can achieve good patency, but it's not necessarily with the longer the obstruction has happened, the worse the production of sperm that you're going to have, and therefore the chances of pregnancy. So this is the vas deferens. We do a 6-point technique using microscopic sutures, and we cut the area of obstruction above and below, and we find two new fresh areas which we tie together. So the patency rate, as I mentioned, is high, about 95%, but the pregnancy rate is only 50% for vasectomy reversal. That's very important to know. Now, another way is we talked about the side to sides from the vas deferens to the epididymis, and this has a lower success rate of only 70% patency and only 30% pregnancy. And this is common for people who have had recurrent STDs or recurrent epididymoarchitis. Now, the last and probably the easiest on the male, the hardest on the female, is to do IVF or ICSI. It's revolutionized treatment of male factor infertility, where we may be able to retrieve sperm from the testis by biopsy or by microscopic testicular sperm aspiration. That one sperm that we are able to retrieve can be injected intracytoplasmically into the ovum and cause artificial type of insemination and hopefully pregnancy. So instead of fixing the problem, you're bypassing the problem by taking the sperm directly from the source. Take home message: male factor infertility does exist. It's easy to evaluate. Many treatments are available depending on the cause. It may cause by genetic defects that can be passed down to offspring. And in the era of IVF ICSI, the urologist is a very important let's say pillar in figuring out how you're going to proceed with the male patient. Any questions? Sorry? Yeah. Yes, but it's a common cause. So you tell the patient, I don't need to evaluate you. Go meet your wife. Okay, so I mean, part of what we do as doctors is we counsel the patients, right? So I don't have to start charging him for 1 million tests while something very simple. Go and meet your wife.
That's when you mean that you don't get pregnant.
Yes, yes. Okay. Any other questions? Thanks for coming early. Good luck on your exams. I'm going to leave this microphone here. Okay.